Okay, welcome everyone to our NephCure U webinar today on kidney care during COVID-19. My name is Kristen Hood. I'm the Director of Clinical Outreach for NephCure Kidney International, and I will be your moderator today in this educational webinar. We have an amazing panel of specialists here with us from Massachusetts General Hospital to speak to you today on kidney care, kidney transplant, and pediatric kidney care during these COVID-19 times. But before I introduce our speakers, I'd like to ask all attendees to remain muted. You should be muted upon entry. Please stay muted throughout the entirety of our webinar. We will offer a short Q&A depending on time. At the conclusion of our webinar, I will be taking these questions from you and moderating them to the physicians. You need to use the Q&A function at the bottom of your navigation bar here in the Zoom toolbar at the bottom. So just hover your mouse at the bottom and you should be able to see that toolbar. You would click the Q&A and you can submit your question that way. We will answer as many as possible as time allows. I do apologize in advance if your question is not answered, but we must respect the time that the physicians are taking away from their clinic and their hospitals at this time. So finally, this webinar is being recorded and will be posted to NephCure's website probably later this week as a patient resources under educational programming. So you can see that on our website, nephcure.org. I would like to thank our COVID-19 sponsors today, which has provided some funding for our COVID-19 educational programming, which is Retrophin, the Pfizer Foundation, and I think that's it. Now it is my privilege to introduce to you some of our amazing nephrology experts. First, Dr. Meghan Sise. She is a nephrologist at Mass General who specializes in the care of patients with chronic viral infections and cancer. Dr. Leonardo Riella is the medical director for Mass General Kidney Transplant Program. He's a longtime friend of NephCure, so we're happy to have him back. And he is an active research laboratory focused on understanding the mechanisms of immune regulation and on the development of novel therapies to promote organ tolerance. And finally, Dr. Weizhen Tan is a pediatric nephrologist at Mass General. Having grown up in Massachusetts and lived in New England his whole life, he really enjoys caring for the kids in his community as part of the Mass General Hospital pediatric team. And so now, as I begin to share my screen, I will turn it over to Dr. Sise.
Thank you so much for having me.
Absolutely.
As Kristen mentioned, my name is Meghan Sise, and I'm one of the nephrologists at Mass General. I'll start with a general introduction about COVID-19 in patients with kidney disease. I'll go to the next slide. And the next one. To give you a brief outline, I'll talk about how COVID-19 may cause kidney damage, how it affects patients on dialysis, and finally, what we know about treating COVID-19 and how having kidney disease may affect how you're treated. Next slide. So I just want to go over some of the information we know about who gets kidney injury. So we don't have any studies that look at patients who get COVID-19 and they don't get sick enough to come to the hospital. We just don't have that information because those patients stay home and nobody really monitors their kidney function. But we do have our good large studies. This one is from New York City of patients who are sick enough to come to the hospital. So this was a study of 5,000 patients in New York City who were sick enough to be admitted to the hospital due to COVID-19. And what they found was that more than 1 in 3 patients who were admitted to the hospital developed kidney damage. And that's defined by your creatinine, which is your kidney test, going up above your baseline, at least 50% above your baseline. And the risk factors for developing this, what we call acute kidney injury, which is that sudden onset of the dropping of your kidney function, is the elderly, those who had black race, patients with high blood pressure, diabetes, cardiovascular disease, and patients who were sick enough to need the intensive care unit. So going into shock and needing to have a breathing respirator are risk factors for having your kidneys injured by COVID-19. Next slide. Another important study looked at patients all across the United States, and it looked at more than 4,000 patients who were sick enough to not only be in the hospital, but be in the hospital's ICU. And what that found was that more than half of the patients where COVID-19 made them sick enough that they had to go to the ICU, intensive care, were found to have kidney injury. And 1 out of every 5 patients who came to the ICU their kidneys were so severely damaged that they needed to have emergency dialysis take place. So this is a very high number for patients who get critically ill from COVID-19. They will require the services of a nephrologist, the nephrology teams. We've been very involved in taking care of these patients who become critically ill. And we think that this rate of kidney injury is higher than other typical viral infections. So it seems like COVID-19, when it's severe enough to make someone very sick and come to the ICU, that is very likely to be injuring their kidneys. When we look at these patients, the patients who were sick enough to come to the ICU and need dialysis, there was a very high risk of death. And so this is really the severest of severe cases of COVID-19. Look at the next slide. I just want to go through the typical way that COVID-19 progresses in a course that a patient may have, and talk about when we usually see the kidney injury part. So usually, and you can see on the bottom on the red, I have a timeline and spans about a 3-week illness of COVID-19. When people first get infected on day 0, they don't have symptoms, and that's considered their pre-symptom phase. Some people stay asymptomatic or without symptoms the whole time they have COVID-19. That doesn't mean they can spread it. We know these patients are a really important part of why COVID-19 is spreading so fast, is because so many patients don't get sick and then they go out in the community and go to parties. So these patients who are asymptomatic or pre-symptomatic, they have no symptoms, but they have a positive COVID-19 test. What may happen is as you get close to a week in, you'll start to get early symptoms, mild symptoms, fever, cough, diarrhea, people starting to realize that they're sick. Hopefully at this point, quarantining and immediately strictly quarantining and getting tested. And so from that point, people can have one of 3 courses. They can stay with those typical early symptoms and have a mild illness the whole time, and they can get better at home. Other people develop what we consider to be moderate illness, where they develop low oxygen levels, they have an x-ray that shows that they have pneumonia from COVID-19. And then we have a 3rd group that develops severe illness. These patients develop oxygen levels that are really low. They need to breathe very rapidly. When they get a chest x-ray, you can see pneumonia all over their lungs. And these are the patients that may end up in the intensive care unit needing a breathing respirator. We see kidney injury developing in that 2nd week. So where patients typically are 10 or more days into having symptoms is when we usually see that their kidneys are beginning to be affected by severe COVID-19. Can we look at the next slide? Next slide. So now I've changed to the bottom half of this slide, now shows what's happening and what's driving the disease. So in the first 2 weeks, we think it's the virus replicating in a person's system, making copies of itself, growing in the bloodstream and in the respiratory tract. And that's why people are sick in the beginning. What happens on week 2 and week 3 is that the body can, in severe cases, can go into a state of severe inflammation. And so the body's immune response that's trying to attack COVID-19 is what's making people so sick. And so when we talk about how we should best treat patients, what are the treatments we should give them? It depends on when their disease is identified. So if it's when they first started getting symptoms and we think that the virus is what's driving the illness, then we think the best treatments are to give antiviral treatments such as remdesivir, which you've probably seen in the newspaper, was the antiviral medication that was approved for emergency use in May to be used against COVID-19. You would want to give that to someone early in the course of their illness when we know it's that virus being out of control in their system. That's the time that we also think treatments like convalescent serum, which is the treatment, where you take the blood, some of the blood antibodies from patients who already had COVID-19 and you give them to someone who newly has COVID-19. That's a convalescent serum treatment. We think both of those treatments should be given early to patients who present early. The problem is this is a time when many patients are staying at home and not coming in for treatment, and we may only see them when they're very sick 2 or more weeks into their illness. At that point, often, if they're very severely ill, the treatment is based on treating that inflammation. So you may have heard on the news that a steroid treatment called dexamethasone has been approved to treat patients later on in the course of their illness, particularly if they're very sick and requiring a ventilator. And so that's dexamethasone. So it depends on at what stage of someone's illness they're in, what treatments we think are the most important for them. Can we take a look at the next slide? So before we talk a little bit more about treatments, I just want to tell you what we know about what COVID-19 does to the kidney. And so we've only known about this disease for a few months. And so we don't have the definitive answers about why COVID-19 affects the kidney. But what we think, based on what we do know and what some studies have shown, there have been some studies where people have gotten kidney biopsies when they had COVID-19, and there's been some studies that look at the autopsies and the kidney autopsies of patients who've had COVID-19. And what we think we do know is that the typical finding on a kidney biopsy is that the tubules of the kidney are very injured. The tubules of the kidney are where the kidney does all of its activities like making urine and figuring out how much salt goes into the urine and all the activities that the kidney has to do to make urine. These cells are very, very susceptible to being injured when someone is in shock or when someone has a severe inflammation, which you can see with COVID-19. So that's the main finding, is an injury to the kidney tubules, those important cells. The other thing we've seen is that some patients can get small blood clots in their kidney, in the glomerulus portion of the kidney. And this has been shown, a lot of people have been noticing that COVID-19 can cause patients to have blood clots. And so these teeny tiny blood clots can happen in the kidney in some patients. And there's been recent reports that African-American patients who have COVID-19 can get what's called collapsing focal segmental glomerulosclerosis. This is a rare disease, but it can be very severe, and this causes heavy protein in the urine. So these are the important findings that we know so far of what COVID-19 can do to the kidney. Next slide. And what about patients on dialysis? So very early on, we recognized how severe of a risk this was going to be potentially to our dialysis population. And I have to give a lot of credit to many of the large dialysis providers and dialysis units that they were very careful early on and doing the best they could to protect patients, knowing that patients on dialysis cannot quarantine at home. Many people are able to quarantine at home and keep themselves safe, and that's truly a luxury. Patients on dialysis have to go to their house. Some people have to go into a transport vehicle to go to dialysis. They may have to go to the hospital for a procedure. They have to go back to their house. And so that was a real challenge. And dialysis units did everything they could to make sure that patients were screened for symptoms, had access to testing as early as possible, and isolated any patient who was being investigated or who was found to have COVID-19. Patients on dialysis, we know the studies show that patients on dialysis are more likely to get very sick when they get COVID-19. Although it's still although it's still not the majority of patients who get really sick, the majority of patients can ride this out at home. We know that you're more likely to get severely sick if you are on dialysis. It's really important that patients know that they can safely come to dialysis and that they don't start skipping treatments. In China, many of the early reports in dialysis patients showed that a lot of the sickness that occurred in dialysis patients were because many of the patients were scared and weren't coming to dialysis, and that many of the patients who died in their dialysis units were because of skipping dialysis. So it's really important, and we're doing everything we can as a community to make dialysis safe. Next slide. You may have seen in the New York Times about running out of dialysis machines, and this is a real risk in a place that gets overwhelmed with a massive surge of critically ill patients. This happened in New York City to some extent, where there were limits, and while there was a lot of emphasis on not running out of ventilators, there's also the realization that dialysis can be a limited machine. So we're lucky in Massachusetts that this didn't happen. We were able to provide all the dialysis we needed to provide in the height of our surge, but we have to realize that our dialysis resources are precious and can be limited. Next slide. So how can you treat COVID-19 in patients with kidney disease? So the next slide. So we talked about antiviral treatments, convalescent serum, and dexamethasone as the three major treatments that people are looking into. I should say that there are literally hundreds, many hundreds of new studies going on to try to find new treatments. So we'll know more in the coming months. But right now we have antiviral treatments, remdesivir, convalescent serum that's being studied, and then dexamethasone. We know that convalescent serum and dexamethasone, there's no reason to think that you couldn't give that to anyone, even if they were on dialysis or even if they were having chronic kidney disease or a transplant. Remdesivir is the only antiviral treatment that's been approved. And unfortunately, that study didn't include patients with kidney disease. So it didn't include any participants that were on dialysis, and it didn't include any participants who had a kidney function less than 30. And so we are cautious about this medicine because we don't know how it would affect patients with kidney disease. But we are, if you look at the next slide, the kidney community and all the leadership in the kidney community is really urging all companies to make sure that when they're running a trial that they're doing their best to include patients with kidney disease. And just, we know that kidney disease is so common in patients with COVID-19 and that we need to make sure that all the treatments we trial. I also want to say that we're hopeful that we'll be hearing more about a vaccine in the coming months, and that will ultimately be, you know, the best solution for this problem. The next slide. And we don't yet know the long-term effects of COVID-19. In Boston, our surge of patients were in April and May. And so we are looking now, as we see patients coming into the clinic, what are the long-term effects of having COVID-19? It's possible that the effects are not just in those 1 to 2 weeks when you're sick, and we'll be studying this as best we can to try to understand what having COVID-19 might do to kidney function. There's reason to think that kidney complications may be more common since in patients who are from ethnic and racial minority groups, and we have to make sure that we're screening patients and making sure that everyone is aware of the potential risks. Next slide. So with that, I think we can pause and I can take some questions. I can open would you like me to open the question and answer?
Yeah, we have one. There are some that have been answered, I think, as we've gone along.
Okay.
But there is a question here from Kevin. He's asking, has routine exercise shown to be any benefit in mitigating COVID-19?
I think that's a really good point. I think haven't seen any actual studies that that have shown this. One of the major risk factors for severe disease in COVID-19 is being obese, and so in so much that people can be eating as healthy as possible and exercising and lowering the rates of obesity, that would be the most important thing you can do for your health.
Great. There's another question here, and I'm not going to know how to say the name. I believe this is a drug name. What about colchicine? Colchicine?
Yeah, I think that's a good question. I think people are thinking about anti-inflammatory treatments, and colchicine is an anti-inflammatory treatment. But I don't know of any studies right now at this point studying colchicine.
Okay. I think it looks like the next question would be for Dr. Tan towards the end. So we can go ahead and turn it over to Dr. Riella. Thank you, Dr. Sise.
Thank you. That was amazing. Meg, thank you for giving this broad introduction. My goal is to talk to you about what happened in the world of transplant and where we are and where we're heading, and the experience that we've gained in managing patients that were transplanted that developed COVID. Next slide. So there are three main questions we'll try to address. I think number one, why should kidney patients that have advanced kidney disease still should consider transplant even during the pandemic? Number two, what are some of the observations that we have learned through studies around the world about transplanted patients that developed COVID? And number three, what are some of the COVID considerations that we have to take it now going forward that we may be applying to our transplant population? Next. So we'll start with just a very basic concept. As many of you know, kidney disease, unfortunately, is asymptomatic until it gets to the more advanced stage. And we know there are blood tests to detect when kidney disease is present. We measure the creatinine. We calculate what we call GFR that estimates how much the kidney is filtering. And we start with a GFR around 100. And as you lose kidney function, only when you get close to the 30, down to the 15, that many of the symptoms of kidney failure appear. What's really important next is that we would like to plan things really ahead. For example, if we're thinking about transplantation, we don't want your kidney function to go down all the way towards 15 before considering transplant. We want a patient that has kidney disease to be referred for a transplant specialist much earlier, when GFR is between 25 and 30, so we can plan things ahead. Next. And this is important as we think about what are the treatment options of patients that have kidney failure. So kidney transplantation is one of them. Next. We have dialysis as well as an option for some patients. Next. And even we have the options of conservative treatment. So this is in particular for patients that may have a very limited life expectancy. So transplantation is not an indication for every patient, but it is one of the treatment options that will give you the best chance of living longer and living a better quality of life. Next. And among all these treatment options, the crucial aspect about what we do is to start thinking, planning ahead. And I think COVID-19 had kind of turned the world upside down, and planning ahead has become something really hard to do. Next slide. So why should we be considering transplant? And if you're a transplant candidate, why should you choose transplantation instead of dialysis? So if you look at risk of dying on dialysis, it's almost 6 times greater if you're on dialysis compared to transplantation. And why is this so much higher than transplant? Next slide. A lot has to do of how effective dialysis is in cleaning up the blood. The kidney has many different functions, but one of them is trying to get rid of toxins that our body produces on a day-to-day basis. Unfortunately, the dialysis is able to only clean about 10% of what a normal 2 kidneys would do. So what ended up happening is, if you think about a car and how an engine requires a very good quality fuel to work well for a long period of time, imagine if you have a fuel that is not as clean, and you put this machine, this engine working through this fuel that is not as pure as expected. In the long run, this fuel is going to start, causing some wear and tear on that engine. And similar is what we see with dialysis. Even though we're able to keep patients alive on dialysis, in the long run, it is something that will be affecting your body, in particular your vasculature, your cardiovascular system. Next slide. So our goal is for patients that are good transplant candidates, and this is something that your referring physician, nephrologist will help you kind of guide you through. Kidney transplantation is one of the best options. And it is an operation that basically places a healthy kidney from another person into your own body. It is a very skilled procedure that you want to be doing it in a center that has lots of experience with a high volume, because your surgeons you want them to be doing that every other day in order for them to be optimized. So at least 100 transplants a year is a center that has a lot of experience and a lot of surgeons with the most work on a day-to-day basis. Next slide. One important aspect about transplantation is that it is a treatment, not necessarily a cure. Next. And the reason I say that is because these patients, when they get this new kidney, they're going to require to take immune suppression for the rest of their lives in order to prevent the immune system from rejecting the kidney. Next. And the reasons why dialysis is better than, transplantation is better than dialysis include that patients will live longer, patients usually have a much better quality of life, and they also will have some independence that will permit them to work and be much more functional than patients on dialysis. And also they will have much fewer dietary and travel restrictions when we are comparing patients that regularly need to be doing dialysis. Next. And this is what happened with COVID. So this is the number of transplants in the USA per week. And as you can see, when we started on the pandemic, there was this huge drop in the number of transplants that were being performed. And in part because we were worried about some of the consequences of COVID in our transplant patients. Two, we wanted to protect living donors and not bring them to the hospital because we also didn't know or were worried that they may catch an infection. And three, there was not enough testing available so that we could test all the deceased donors that we're getting. And the hospitals were overwhelmed with the number of patients. So a lot of the centers, including Boston and New York, where we saw a very acute rise in the number of cases that we were seeing in the hospital, the transplant programs were shut off in order to be able to take care of those patients and also to think it very carefully, when is it safe to reopen? And as you can see here, we have some good news. So our numbers are back up to what it was before. I think in part because, you know, some of these spikes in a lot of places in the US have basically gone down, and because of all the other interventions that have been done, and also because we're doing much more testing now and we know what to expect. Next. And it has been, you know, this balance between, okay, click twice more, please, Kristen. So you have on one, oh, maybe go back one. Thank you. So you have on one side the risk of COVID and the risks involved with going through a surgery and bringing the patients to the hospital. And on the other side, you have the potential benefit of getting a patient off dialysis, that we know they're going to improve their quality of life. We know that they're going to live much longer. And it's a balance where we needed to find a line of where to draw and where to kind of reopen our programs. Next. And a lot of the hospitals that have been involved during the pandemic, they have adapted their routine. So now, for example, at Mass General, we have this e-checking. So patients check in before even coming to the hospital to make sure they have no symptoms. Once they come in, both providers, healthcare workers, and patients, they go through a checklist. There's no visitors allowed in the majority of places, just to reduce the number of patients or individuals that are in the hospital. Everybody's wearing a mask. We're doing the 6 feet apart. The clinics are not as crowded. We're starting to space out. The cleaning and disinfection is much more intense. And whenever somebody's suspected of having COVID or have COVID, they are being placed in a separate place in the hospital. So there's definitely a lot of geographical separations to try to minimize any risk of transmission. Next. And in the healthcare system, there was being a very fast, I would say, embracement of virtual visits. So virtual visits include the video conferencing that you may do with your physician. And transplant has been one that, you know, we've seen that it has a huge benefit from patients that are referred for transplant, that we can start the evaluation through a video. And then for patients post-transplant, that we want to minimize their visits. In particular, if things are going stable, they can get their blood drawn locally and they can just consult us through the video. So I think this is, you know, it's convenient, it reduces costs from the travel, from the parking, and it has so many other safety measures that a subset of our patients would absolutely benefit. And I think it's really important for you to be looking for centers that are using that on the day-to-day basis, either for the referral process or post-transplantation. Next. And, you know, as we were facing all the pandemic around, the biggest questions that many of you have seen on the question and answer that has been posing was, what's the impact of patients that are taking immune suppression, they're taking anti-rejection medications when they develop COVID? And in order to have an idea of what's really happening, we partner with centers in Italy and Spain. And this was a study that was just published about a week and a half ago, where we got 12 centers, large transplant centers around the world, mostly in US and Europe, where we had, you know, a huge pandemic recently, especially centers like Boston and New York that we started seeing that peak earlier. And this covers about almost 10,000 patients, 10,000 transplanted patients across all those institutions. Next slide. And this is what we were able to observe. So among those almost 10,000 patients, about 144 kidney transplant patients were hospitalized because of COVID. So that's about 1.5% of all transplant patients across all centers were hospitalized because of COVID. And then we look at some of the risk factors of why some of these patients did worse. And I think what it appeared also in the general population as well as in the transplant population was that older patients tend to do worse, across, if they're immune suppression or without, and also patients that have other comorbidities, other diseases that may affect the immune response against the virus, and in particular, diabetes and obesity were major risk factors for a worse outcome. And then we also wanted to look at what happens with some of these patients. And as we've seen in the general population, about half of the patients that were hospitalized with a kidney transplant developed COVID. They had some sort of kidney damage or some sort of the reduction in kidney function as analyzed by blood work. And about 1 of every 3 that were hospitalized requiring intubation, and 1 of every 3 ended up dying. What I want to put it out here is that we are documenting here the sickest of the sick, okay? So there's a huge amount of other patients that did not get to the hospital and they were not hospitalized that we are unable to capture yet. And I know Kevin had asked this question, why we're not able to capture this. In part is because the COVID testing is not as available as we would hope. So many centers still have some criteria for testing so that because we don't have enough kits at the beginning. And this was a major flaw, I think, in the controlling of COVID in the United States, is that there were not enough kits to keep testing people, even people that had a low suspicion. So we had criteria to just test those patients that had the higher risk of having the infection. And so this limits us the interpretation. So among all patients, transplant patients that may get infected, only a minority is the ones that are going to be hospitalized. And as you can see, the minority that get hospitalized that had a worse outcome are usually the older with other comorbidities. Next slide. So in the question we also had at the same point, and I know there were also some questions about this, is, you have someone that got a transplant, they're taking immune suppression, anti-rejection medications. The goal of the immune suppression is to weaken your immune system so you don't reject the organ. But at the same time, that same immune system, the same army that your body has, is the one that's going to fight the virus. So if you're if you're suppressing that army, how are transplant patients generating a response against the virus? Next slide. And this is what you see on the right. So we had a lot of these hospitalized patients, transplanted patients, that we look at their antibody generation. Were they generating antibodies against the virus, similar to what we were expecting in the general population, so they could help get rid of the virus? And to our surprise, the majority of transplant patients were actually able to generate an appropriate antibody response against the SARS-CoV-2 virus, the virus that causes COVID-19. So even with the presence of the anti-rejection medications, majority of transplant patients will generate a good response. Next slide. So overall, how are we approaching immune suppression and how are we approaching COVID-19 in transplanted patients? So immune suppression adjustments should be individualized. So we are not recommending lower immune suppression just because somebody is transplanted and just because around the corner there's some people that had developed COVID. So we have to be very careful because there's the balance between allowing your immune system to fight the virus and on the other side your risk of rejection. And we don't want to touch too much on the immune suppression if we don't need to. In patients that are severely ill, I think the majority of centers, with the guidance of your physicians, will reduce and will adjust the immune suppression. And the main medication that will drop the dose, it's going to be the mycophenolate or azathioprine. Okay, these are the anti-proliferative immune suppressive drugs. The second point is that, as Meg was commenting on, there's additional approaches that we should definitely consider in our transplant patients, including antiviral treatments such as the remdesivir, or treatments that may control the inflammation, okay? And this is different than anti-rejection medications. A lot of the medications that we take to prevent rejection, they're aiming towards a different part of our army that fights, for the rejection process. And those are primarily T and B cells. When we're talking about inflammation, those are the innate immune cells. So our other subset of cells they need another type of medication to try to control it. And this is a little bit higher doses of steroids. That's some targeted therapy such as the anti-IL-6 receptor or even colchicine. So I know there was a question about colchicine. We have a study that we just submitted looking at colchicine in some of these patients. And we've seen some interesting results. And again, it's limited number of patients, but there are a couple of ongoing trials. They're randomizing people to colchicine. So we need to follow up on that data to look for other potential drugs that may control the immune system, in particular the inflammatory part, because that inflammation seems to play a major role at the end. So overall, what we've seen is that in centers like Boston, that the hospitals are not overwhelmed anymore. The transplant centers are open. We are taking all the precautions possible, and we should not be delaying patients to be referred for transplant or to get transplanted right now. So this is what's happening geographically in the Boston area. If you may be in an area where your hospital and your nephrologist tells you that the program is on hold because they're overwhelmed, you should follow their recommendations. But fortunately, we here in Boston now, we're open, we're taking all the precautions, and now it's safe to move forward and get patients through the transplant. And now we have learned at least enough about some of the other cases in Italy, in Spain, in the US, of how to manage COVID patients through the transplant and after, if they get infected. And we feel strongly that we should try to pursue that, just because on the other side, for patients that are candidates, dialysis is not a great option in the long run. Next slide. And I'll thank you, and I'll take any additional questions.
Okay, great. I do think that some have been answered as we have gone along. Let's see, how does it, this is from Angela, how does it look going back to work as a barista, very immunosuppressed and 6 years after transplant?
Great question. So, you know, the masks have been help at least some of the, spread of the virus. And fortunately, we don't know exactly, or unfortunately, exactly how much of that prevention will happen. So we want to try to minimize at least the traffic and avoid as much as possible. So it's really hard, I think, to give you a straight answer there, just because we don't know how much of these interventions may be minimizing it. If you can wear masks that are even more protective, such as the N95, if you're immune suppressed, this could be something that could be definitely entertained. And I think, the more we can minimize at least the contact with other people in a closed environment, those are things that we should definitely try to pursue. And you can discuss more in your individual cases with your transplant nephrologist that, of course, it is a learning curve now that we're all passing through. So I'm sure there won't be kind of right or wrong answers. And it's kind of balancing a little bit of where we draw the line in individual cases like you.
Absolutely. Frank has a question related to vaccine development. Do you know if companies who are developing vaccines are addressing the clinical efficacy in transplanted immunosuppressed patients?
Yeah, so I think the first trials that will come out will exclude transplant patients, and in part because they're trying to test the efficacy. And we do know that immune suppressed patients tend to have a slightly lower efficacy in mounting an immune response. What we know about the COVID-19 vaccine is that they're adding an adjuvant that's going to be very powerful. So is it possible that it may trigger the immune system in patients that got a transplant? It may be possible. I think we will only know after we test it. So once the drug is approved, once the vaccine is approved for the general population, in parallel, we'll launch a research study where we're going to be testing that in the transplant scenario, so we can kind of monitor patients very carefully. So as soon as that is approved, the companies will not accept testing on transplant patients before it gets approved through the general population. So we're going to keep pushing them so that as soon as that's done, we're going to have the protocol ready to push it so that we can offer for our patients going forward.
Great. And I'm going to give you one more question. We'll move on to Dr. Tan after this. It's actually a clarification from Bill. He's asking to clarify your slide that showed 1.5% of transplant patients hospitalized is of all transplant patients, or is it 1.5 who contracted COVID with transplant? Does that make sense?
Yeah, so that's all transplant patients that are being followed through all the centers that had a big pandemic in their region. Only 1.5% of all those transplant patients got hospitalized. We don't have yet the total number of patients that may have gotten infected. Probably is much higher than that. So we're just seeing the tip of the iceberg. So hopefully now that we start doing more broad testing in more individuals, we're going to be able to give you an exact number of how many people actually got infected. But I think we're just talking about the tip of the iceberg and the cases that unfortunately have the worst prognosis. So that's why these patients are not doing so well. I think there's a whole group of patients that got infected and ended up never having such severe symptoms as we have documented those in the hospital. And there's a question about the rituximab, and I can add a little bit about rituximab because we did a study looking at rituximab in particular in patients with nephrotic syndrome and seeing if they were a much higher risk or not of developing COVID-19, and looking primarily in kids and adolescents. And we did not see a much greater risk of getting COVID, and also not a much greater risk of getting severe COVID. These are small cases, but fortunately, it seems even in high cases of where family members got infected, these kids ended up not developing the infection, or some developed mild symptoms and developed the antibody without even getting the severe symptoms of the infection. But these are things we're just kind of learning as it goes at this point.
Thank you, Dr. Riella. Thank you so much. You might find there's some more questions that maybe you could answer while Dr. Weizhen Tan is presenting as well. So thank you so much for your portion. Dr. Tan, I'm going to turn this over to you now.
Okay. All right, thank you for letting me speak on coronavirus and how it affects kids with kidney disease, and also just kids in general. And so hopefully I'll be able to provide an overview of COVID-19 in children and able to discuss some recommendations regarding returning to school. And I've been trying to discuss that in the chat as well. It's definitely a hot button topic. And any special considerations regarding our pediatric patients, especially those who are on immunosuppression, who have received transplants, the administration of vaccines, not just the ones that are being developed for COVID-19, but vaccines in general, and certain medications for patients with kidney disease, which also has been already discussed in the chat as well. So next slide. So to give some context, I think to place children in context, I'll start by showing a map of COVID in the United States. It's obviously not equal everywhere, given certain hotspots, as you can see in the Northeast, Southeast, and West. But as of yesterday, I looked it up yesterday from a New York Times map, there's estimated over 4.6 million cases of coronavirus in the United States, with greater than 155,000 deaths. But the question is, how many of these are children? Next slide. So fortunately, the data in the United States and other countries suggest that children are not as easily infected as adults. So rates starting from the beginning of the pandemic in maybe March until now have changed as testing has increased in the United States. So for example, in April, CDC study demonstrated about 1.7% of cases were among children less than 18. So of all the people who tested positive, only 1.7% were in children under the age of 18. Whereas as testing has improved, the rates have risen. Most recently, it was 8.4% in the last study released in the end of July. And then specifically at MGH, we looked at our own data, and as of late June, we had tested about 6,800 children, and only 787 of them were positive. So the rate that kind of mimicked the early studies, which were about 1% of the time, it was positive in terms of infection. But I think as testing has increased and improved, and as restrictions have been lifted, the rate of positivity has risen in the United States for children, and currently it's about 380 cases per every 100,000 children. And that's the current data, and that will change as time goes on. And again, another thing that we have to notice, if they get sick, which seems to be less, are they at the same risk as adults? And the answer seems to be no. So looking at the data from the end of July, this came out from the AAP, about 44 states reporting in New York City, of all ages, there have been about 121,000 deaths as of late July. Only 76 of them were children. And so that means that of all children who got it, resulting in death was 0.03% as a death rate. So that's pretty low compared to adults. And when you look at symptoms as well, they don't seem to get as sick. So in early studies, we have shown that patients who are less than 18 had symptoms about 73% of the time, consisting of either cough, fever, or shortness of breath, whereas adults had it 93% of the time. And then patients who got it, who are pediatrics, were hospitalized at a lower rate, so maybe 5% of the time as compared to 10% of adults. And we talked about the death rates there as well. Okay, here, next slide. However, although children don't seem to get as sick, there is a new entity, something called multi-system inflammatory syndrome in children. What is this? This seems to be a rare condition that happens in children in the setting of COVID. Usually happens weeks after the infection has been cleared, so they may not even know they were positive, as sometimes they don't get tested if they're relatively asymptomatic. And then it causes inflammation in multiple organ systems, including the heart, the lungs, sometimes the kidneys, and then of course other things like skin, eyes, and the gastrointestinal tract as well. And symptoms can be quite varying, but overall it's symptoms of inflammation. So they have fever, abdominal pain, vomiting, diarrhea. They feel generally irritable as well. And the data shows that it was first described in the United Kingdom in April, and then one study in June was looking at the population in New York, where there are about 15,000 pediatric cases in early April and March and May. In June, and only 99 of them had the multi-system inflammatory syndrome, so 0.6% of total pediatric cases. And so it seems to be very rare. And currently, as of late July, the current rate is about 2 per 100,000 cases in those less than 21 years of age. So if you think about the COVID rate was about 380 currently, of that, only 2 per 100,000 seem to develop this multi-organ inflammatory syndrome. But it is more serious. More patients require an ICU stay. In one study, up to 80% of patients require an ICU stay and have cardiovascular involvement and even death. So in New York, this one study, there were 4 deaths in New York. 2 out of the 4 deaths were attributable to complications due to this multi-organ inflammatory syndrome. Next slide. But it is rare. So take-home points for children regarding COVID. The data does suggest that so far children seem to be less affected by the virus and generally have good outcomes. And there is evidence to suggest that younger children, those who are less than 10, are less likely to be infected compared to their peers who are older. However, this does not mean that children do not get infected, right? The published lower rates of infection and death probably mean that if children are exposed, they seem to clear the infection sooner than adults, have less symptoms, and therefore may not get tested. So therefore, as testing has increased, that's why I think we are seeing that the rates of infection in children have seemed to be rising as well, from 1% now closer to 8%. And we will get to our immunosuppressed patients later, I feel, if we have time to talk. So then the next question is, what should we do about this, right? Should we, reopen schools? That as the fall approaches and summer ends, I think this is a topic that everyone's really, worried about. So I think we just have to weigh the risks and benefits. So if you go to the next one. So the biggest risk, I think, obviously, is spreading the virus. If we send children back to school without any restrictions, the risk of spreading the virus seems to be increased. And of course, with that, it's not just kids. The teachers have a major concern, right? As adults, teachers are very concerned about what's going to happen to them if they get exposed and sick, and what happens to their families as well. And then caretakers, I think that, again, not every child or every family has a similar family situation. There are many people who, due to their living situation, cannot socially distance. So if the children get exposed and bring it home, grandparents, people with, immunosuppression, people with other comorbidities may get sick and exposed as well. So those are the major risks that people are talking about when it comes to reopening schools, and those are legitimate concerns. But then the benefits of school, I think, are a little bit more nuanced, but have real implications when people have to discuss reopening schools. So number one, I think not every child will be able to effectively learn if it's a virtual environment alone. There are many people with special needs and autism and need the in-person teaching that in-person school provides. Obviously, in regards to working parents, the economy has taken a hit, and if school cannot reopen and parents have to stay at home with their children to help them learn virtually, then many parents are not going to be able to work, and that could be hard for certain families as well. And then not everybody has the resources to just stay at home and not work. There are many families that rely on school for their school services and social services. For example, school lunches, free lunches, screening for domestic violence, as well as, of course, special education. So there are many kids that need school services and can't get effective services at home. And of course, mental health. There are many patients when the untold damage for staying at home and not socializing with your peers has definitely led to an increase in anxiety and depression in our pediatric patients as well. So I think there are benefits to school that are harder to quantify, but are definitely important when discussing reopening school. So overall, I think there's little argument. Yes, you can go to the next slide. There's little argument to discussing whether school is good, but only if it can be done safely. So, what does the data say about school reopening? Before I go to the recommendations, we looked at other countries, and the studies show that those other countries who have already opened school, what is happening in those places? So it seems to show that those who are younger seem to have less infection, right? And in Israel and in Spain, it seems that household contacts, patients who have gotten an index case of coronavirus, the adults in that household seem to have a higher rate of infection as compared to the children, who have much lower rates of infection in that same household. In France, there was another case report of a 9-year-old who had coronavirus and flu early on in the season of coronavirus. The flu was spread to contacts at school, but coronavirus was not. So it seemed to be less infectious to children who are younger as well. And other countries like Denmark, the Netherlands, Germany, they have all opened schools and seem to have kept their rates of infection relatively flat. But on the caveats on the other side, Israel did have an outbreak in high schools, but this seemed to be related to restrictions on mask wearing. As they released those restrictions, the outbreak happened in Israel. In the United States alone, we don't have that much school data, obviously, but in one study, the YMCA had emergency daycare for ages 1 through 14, and there were 40,000 children in 1,100 sites. And there are only a few adults who tested positive and no children who tested positive in this setting, and no more than one person per site. So that seems to be reassuring as well. But finally, last week, I think there was an article that came out. And again, everything that we say has to be taken with a grain of salt because the data changes minute to minute. And so last week, a study came out in Georgia. There was an outbreak in a camp, a summer camp, that showed that without proper restrictions, even the children who are less than 10 years of age seem to get infected as well. So that is, a data on the other side. So what do people have to say about this topic? So, people smarter than myself have come together, looked at all the evidence and made some recommendations as well. So the AAP, for example, has guidelines regarding reopening school and giving some recommendations for school policies. The New England Journal of Medicine, there was just an opinion piece published last week about reopening schools and whether we should reopen schools as a society or not. They definitely lean towards reopening schools for sure. And then Pediatric Infectious Disease Society of America definitely released some guidelines, which I'll talk about as well. And then the CDC, of course, has some resources for patients who are immunosuppressed and those who are not regarding schools and childcare programs. So we'll talk about that if you go to the next slide. So in regards to our parents and patients, I put some links here for reopening schools. I think the CDC just has a good link there for a decision tool. So if you are concerned or have questions about whether your own community is safe to reopen schools, there's a checklist there that you can answer and kind of help you make the decision whether you think it's safe regarding going back to school. The Infectious Disease Society released recommendations, especially patients for solid organ transplant who have immunosuppression. So for patients who have kidney transplants and then for patients who are on immunosuppression who don't necessarily have organ transplants, I think these recommendations may be useful regarding guidelines of deciding how to go back or whether it's safe to go back. And then most importantly, I think in discussing making the decision for yourself, I think if you are making that decision, I think it's important to talk to your school system yourself whether through an IEP or a medical 504 plan, if you're able to talk to your school system and see what they're doing regarding reopening, and if there is a way to, mitigate risk for your own immunosuppressed patients and children, whether you can reduce risk regarding, maybe early dismissal time or early admission time to avoid crowds, whether you can position the child close to the door, away from other children, and increase the distance, things like that to mitigate, maybe getting a parking spot close to the school so they don't have to take the bus. These are things that we can do and discuss with your school system individually to try to limit your risk. Yes, so those on immunosuppression, special consideration for our patients' immunosuppression. So like Dr. Riella said, those with kidney disease or status post-kidney transplant, we do not recommend empiric reduction in immunosuppression. I think it is important to maintain your medication to treat your underlying disease or prevent rejection. However, there is the recommendations from the Infectious Disease Society suggest that maybe if you have a higher immunosuppression regimen because you've recently been transplanted or you're getting treated for rejection, so you have to have increased anti-rejection meds or immunosuppression meds, then you may be at higher risk, and therefore you may want to consider, curtailing your return to school in that setting. But pediatric patients in general, compared to adults, they don't seem to have as many comorbidities, as Dr. Riella said. They don't have the untreated or longstanding diabetes. They don't have the obesity compared to our adult colleagues, and the cardiovascular disease that the adult transplant patients seem to have. So it seems to be that by case reports, that pediatric patients with solid organ transplant seem to do well. We don't have the large data to follow pediatric transplant patients with COVID, but from the case reports that have been published, those patients who have gotten it and are on immunosuppression seem to do well. And the death rates overall are still very low in this country for all pediatric patients, regardless whether you have immunosuppression or not. But of course, you have to be careful. And then regarding vaccines, I think the coronavirus vaccine is still is being developed, and we'll see what happens. But I think one major concern that we had is that if you looked at New York or nationally, what happened is that as the national emergency was declared and people shut down, no one went to the doctors, and measles-containing doses dropped 3 million. Non-influenza doses dropped 400,000, so nobody got vaccinated. And there was a big push, especially in New York, for example, from the Department of Public Health to increase vaccination rates, to bring patients back in, to get them vaccinated. And we have luckily seen, or fortunately seen, a rise in immunizations across the board over the last few months. And it's just important to show that we are aware of this, because children, whether you're immunocompromised or not, whether you have COVID or not, you're still at risk to get other viral illnesses too. So it is important to get vaccinated for everything, regardless of whether you even have COVID or not. And then lastly, I don't know if we have time or not, but briefly for medications, we've talked about Plaquenil and other drugs as well. But regarding ACE inhibitors, I think there are some theories that ACE2 is the receptor that brings coronavirus into the body. There are some theories that suggest that if you're on ACE inhibitors, that could increase your risk for viral binding and getting the disease. And some evidence suggests that it would actually help prevent fibrosis in the lung, so it would actually be beneficial. So there were some studies to discuss whether you should stop ACE inhibitors, and I want to say that the evidence suggests that you should not stop ACE inhibitors. If you go to the next slide, there are many adult and pediatric societies that have recommended that you do not stop taking this medication. If you go to the next slide, just a whole list of societies that recommended that you continue to take this medication and not stop. Obviously, if you're very sick, we can talk about that in general. So I know that was very quick because we're running out of time now. It's almost 3 o'clock, but in summary, it seems to be that COVID-19 does not affect children as badly. Children still can get exposed, infected, and can expose others, but seem to just not get it as affected as badly. Returning to life, I think, is important, and we must all weigh the risks and benefits of going back to school and to work. And I'm just trying to really highlight the point that for our patients, we have to be, follow local guidelines, be flexible, see what our local school systems are doing, see what the local community transmission rates are doing. And if the transmission rates are low, if there is good mitigation strategies to have mask wearing, social distancing, and a hybrid plan to go back and forth, if the rates rise in the community to go back to virtual, then I think it's reasonable to consider sending your child back to school. But if not, then I think you really have to weigh for yourself as a personal choice, is it safe to go back, and it may not be safe to go back depending on what's going on in your neck of the woods. And then when the time comes, obviously get vaccinated as much as possible, and be in contact with your own physician regarding your individualized care as it comes to transplant, immunosuppression, and what medications you should be on. And it is 3 o'clock right now, so hopefully we can answer some questions if they have not already been answered.
Yes, thank you so much, Dr. Tan. We do have a couple of questions here for you. One attendee says, thank you. I've heard probiotics are very beneficial. Is it safe for a child 3.5 years old to have probiotics while on steroids?
So in general, I think probiotics are generally well tolerated. We have patients who are on steroids who then get infections or UTIs, for example, and they get diarrhea. And yes, we've put them on probiotics. And I don't think while you're on steroids and probiotics, I don't think there's a contraindication. I don't know if Dr. Sise has any thoughts about that, but in general, I don't think we say probiotics are contraindicated to patients who are on steroids.
I have 2 cents on that. The only careful thing is that there are different amounts of probiotics that sometimes are sold and some require prescription. And we've seen in some of the immune suppressed patients, if they give you like a really high dose, there are risks of infection when you give that. And there's a lot of unknowns about some of these probiotics. Is like, what is a good probiotic and what is its content? So I think, you know, in order to have a healthy microbiota, so the bacteria in your gut, I think if you focus a lot on your nutrition and having a lot, you know, high fiber content, vegetables and fruits, that can potentiate, give prebiotics so that your microbiota becomes very rich and diverse. But as Dr. Tan was sharing, some patients that are taking antibiotics or taking other things that may kill a lot of the bacteria in the gut, those probiotics can help reconstitute that in the short term.
Thank you.
Thank you. There's another question here from Cheryl. Is there an increased risk for children with autoimmune kidney disease or overreactive immune system to develop COVID symptoms or complications of kidney disease due to COVID diagnosis?
So that's a tough question, because when you say autoimmune kidney disease, it could be like lupus or vasculitis that can lead to an overactive immune system. And again, I don't think we have enough data to show, like, if you have those diseases, are you at higher risk to develop complications from COVID at this point? And again, I think it depends on what your treatment status is. If you're in remission from your ANCA-vasculitis and you're on very low dose immunosuppression, I think you should be doing very well. If, you know, hopefully if you're young and you have no other comorbidities, if you unfortunately get it, you hopefully will do well. But obviously, if you have active disease and you're on high dose immunosuppression, and if you get ill, then of course you may get sick. And so the question is very hard to answer at this point without much data that we have.
Great. I will tell you, here at NephCure, I think we've answered most all questions throughout the webinar and in our Q&A after each physician. But real quickly, just in the last minute, you know, here at NephCure, we have heard of increasing number of people who have been diagnosed with FSGS after a COVID diagnosis. And so I'm curious, Dr. Sise, if you have seen this, and are you treating these patients differently than if they were more of an idiopathic nature of diagnosis?
A really good question. You know, it's very hard to treat any kind of FSGS particularly that occurs in a viral infection. The studies so far have shown collapsing FSGS, which is one of the hardest kinds to treat. So I'm not yet aware of any, other than we usually just do sort of supportive care to get through the virus. If a patient then for weeks after is still having heavy protein in the urine, could consider a course of steroids, but it's not, you know, there's not clear treatments. I currently haven't had any of my patients who have gotten that, but
do you know if there's like a registry for patients if they get glomerulopathy or, you know, podocytopathy after COVID? Would there be some place they could go so that they could be a part of any research? Are you aware?
No, that's a really good idea. That's a great idea, because it's going to be a rare outcome. So any one nephrologist is not going to see many patients with this problem. I know that one of the participants asked about the FSGS, and I did put a link into an article that summarized several cases of the FSGS that occurs after COVID-19. And I know that that was at multiple different hospitals. So it's not even like any one hospital has seen dozens of cases yet. It is still a rare finding.
We're still learning, aren't we? We're still learning. Yes. Well, thank you so much. We did go a little bit over. I appreciate you, Dr. Riella, Dr. Sise, Dr. Tan, for being here with us today. I know that our patient community really appreciates this. This was definitely a record webinar for NephCure, and we appreciate you very much. If we didn't get to answer your question, we will try to do so afterwards, but thank you so much. Have a wonderful day, and you know, always you can find us at NephCure at www.nephcure.org. Thanks so much.
Thank you, Kristen.
Thank you.